Well, good day, everybody. Today, I'm going to talk about, in short, about what is renal trauma because often our friends do have a question on renal trauma. Sometimes they have a question on the Viva table as well. Now, for this, I need to share my screen for my presentation. Okay, so let's go dive deep. Now, the most important thing, because I'll be going very fast in this because this is part of my of a online course. I just you can find it in my website. But normally, kidneys are well protected organs, so it will take more than severe injury for the kidneys to be damaged. Okay, and the etiology of renal trauma is mostly they can be a penetrating like a bullet shot injury, or it can be a stab injury, or the most likely they are blunt rapid discharge because like a person on the front seat having this seat belt on, and then they are pushed forwards by the impact of an accident or of a road traffic accident, motor vehicle crash, or the person is falling from a height. Okay, or it can be just in some cases of arthritic due to surgical misadventures. And so what the classification is, so the grade one is basically a contained renal contusion, subcapsular hematoma, which is contained, it's not expanding. But if it goes beyond beyond into the renal capsule, expanding renal hematoma becomes a grade two. But whenever this is still laceration of the kidney, becomes a grade 3, and the laceration can in fact involve into the pelvic calcium system as well. Now, if there is any form of injury of the major renal vessels, becomes a higher grade injuries, including a shattered kidney, becomes a grade 5. Okay, so as you can see, it's just expanding hematoma, and which may cause rupture. And these are the cases where you have to be very cautious to go for an operative intervention at the very early beginning. Small lacerations, small contusions can be basically managed conservatively. Now, as you can understand, with about 50% of the renal trauma can be isolated, 50% can be associated with other organ injuries as well. Like they can be associated with splenic injury on the left side, and pancreatic injury, as also liver injury on the right side. Okay. The presentation is obviously high risk of index of suspicion. You can understand the patient can have symptoms of abdominal pain, the patient can have ecchymotic signs, and even have what is known as the amateurism, because the blood, often the blood which is goes through the renal parenchyma into the peritoneum, can cause interperistaltic signs. Okay, and peritoneal signs. So that's very important. So the most sign qua non of renal trauma again is the hematuria. Okay, the most important renal indicator is gross or microscopic hematuria, because in a child, even any form of hematuria, even microscopic, is an indication for imaging the patient. Okay, so any form of, but in adult patient, macroscopic hematuria or microscopic hematuria, any form of vital stable dysregulation, destabilization, obviously you have to do the investigations. IVP role, well, IVP is not done in the emergency department, is only done in, that's very important, it's done in the operating table. Okay, and this is a one-shot IVP where you give 2 ml per kg body weight of an non-ionic contrast media IV, and you follow up with a single abdominal radiograph for 10 minutes. Okay, there's no need for south film. It's only to see what is the status of that kidney which is injured, and what is the state of the other kidney, whether the other kidney is also normally or not. Okay, often you can put some radio opaque markers like a paper clip to know what is the entrance and the exit tracks of the, and you can corroborate the entrance and exit tracks known as the what is the pathway that the bullet has traversed. Okay, so that's it. Basically, the functional anatomical assessment of both kidneys and uterus, nothing else. Okay, so you can be understand that there's two functional kidneys present when you do a one-shot IVP. It's on table, never on the emergency department. CT is the investigation of choice. If the patient is stable, they can be accurately and completely imaged at stage. But the patient is unstable, why do you want to waste your time taking the patient to a CT gantry image? And then again, if the patient is unstable, go for the ABCs of resuscitation, and then just strolling the patient right into emergency, emergency operation theater for ciliotomy. Okay, that's not a emergency ciliotomy. And in that case, we do a one-stage, one-shot IVP. It's both sensitive and specific to different vessels. That's the grading is basically depending on the CT. There's no much role of fast or the ultrasound at the emergency department when we talk about renal trauma. Okay, so that's it. The role of angiography is basically, this is the fast, this is the helical CT. scanning very quick. It's done within 10 minutes. All the information you will get. All information you get. Angio basically is only when you believe that there is a role of CT guided angioembolization. Okay, so symptomatic post-traumatic IV fistula, a persistent delayed renal bleeding, or severe hematuria. You need a CT guided angioembolism. Then only go for angio. Okay. So this is Santucci has described treatment approach considerations that operate immediately if the patient life-threatening bleeding, obviously, or else observe initially and then go accordingly. Right, angioembolism or non-emergent bleeding or urgent bleeding if those techniques are available in your center. So basically center specific. Okay, so surgery renal trauma mostly they end up in nephrectomy. Very few surgeries do achieve renography and they come out. Most of them are very dire emergency states and you have nephrectomy as the only available indication. Now, what are the indications? Obviously, incomplete stage renal injury requires surgical exploration. You cannot stage the renal injury properly. Absolute is an external trauma, persistent renal bleeding. Okay, when the person has a bullet injury or stab injury, well, and the continued renal bleeding is a pulsatile expanding, uncontrollable retrovenous hematoma. Then you have to explore. And there's an avulsion of the main renal artery and vein as well as CT angiography. Okay, and relative indications are in non-viable tissues. You can see on CT because these are source of infection later on, sepsis and abscess, all these things. So three risk factors which are not included in grade 4 injury but also very important, and the need for surgery when associated with the hemodynamic instability is a hematoma, perineal hematoma more than 3.5 centimeter, intravascular contrast exacerbation, and medial renal lacerations are more likely to cause this pelvic uterine junction disruption. These are very important because a person like a desertion injury, the whiplash injury, the person is sitting on the front of the car, thrown in front because of that impact of an accident, or he's falling from a height. These patients have pelvic ureteric junction disruption. This is a major injury, but the patient doesn't have any hematoma or any hematuria because the renal artery vessels are intact. So even this is a major injury, and you may not be detecting it by seeing hematuria on the blood when the patient passes urine. It has to be detected. You have a high index of clinical suspicion and do a CT, and then you have to go in right there. Okay. So this is it. Additional relative indication, major devitalized years with the urine extravasation. That's what I talked about. Extensive renal injury and large intraperitoneal hematoma, even without intraperitoneal injury. So in the absence of person, hemodynamic instability coagulable, the renal reconstruction is safe and effective. Again, you must have adequate time to go for renography. Indication effect with grade 5 injuries, shattered kidneys, by an uncontrolled hemorrhage. Obviously, you don't have it, no other indication. So that's it about in short about the renal trauma. It can come as a short question, as an emergency situation. And if you have any comments, please note in the comment section, or else you can mail me in my this thing. My mail ID I've put forward, or you can just go to my courses section in my website. Okay. So I hope to come back again in the next class section in our playlist. Stay fit and be with me. Bye bye.